Welcome back for the last time today. Before our fifth panel on patient flow, we have Richard Jones, Chief Strategy Officer from C2 AI Net, joining our virtual stage for a keynote session. So over to you, Richard.
Thank you very much. So C2AI, basically we're doing a variety of things in the elective recovery and helping in these most difficult of circumstances. We're very pleased that with work we're doing with various partner trusts that we've been nominated for a couple of HSJ partnership awards. If we go to the next slide, we've actually won quite a lot of awards for what we're doing. But I think most important on here is that the estimate is that we could save something like 70,000 lives and £1 billion of direct in-year cost for the NHS. This was before we actually started working on elective recovery. And probably it'd be fair to say that the numbers now would be closer to north of six figures and about 3.4 billion of in-year OPEX. So no nursing cost in terms of reduction in nurses and no reduction in CapEx that goes with that. And systems designed by clinicians for clinicians. So if we go to the next slide, just want to give you a view of really how bad things are and the challenge that people are facing. So we're trying to put people into three buckets in terms of priority based on the Gregorian calendar. So do we see in the next 4 weeks? Do we see between 1 month and 3 months, or after 3 months? These are real outcomes for patients who are waiting for a hernia repair. On the left-hand side, you can see those who actually were seen electively, very low mortality rate, a few surgical complications. That's the kind of the orangey red bar. Those who came as an emergency, far more serious. So there we've got the mortality going north of 4%. We've got a significant number of complications. And what that means is we've got people hanging around in beds, blocking beds, reducing ICU capacity, and meaning that it's going to take us longer to fix the waiting list. But on the right-hand side, there are also a percentage of those patients who come in and are too late to be operated on. With them, the mortality is rearing up towards 19%. And you can see conditions that are acquired in hospital actually spiking. So things like AKI, typically that'll keep somebody in hospital for another 6 days, regardless of their normal length of stay. So it's another 6 days. Costs about £4,200 in direct costs. The yellow bar, hospital acquired pneumonia, 8 days and £1,800. So if you then take this across all the different types of operations that there are and the different comorbidities that patients have, it's exceptionally difficult to optimize the waiting list. And the headline would be that what we've seen as a result of the delays and the challenges is that mortality rates are doubling, and we're getting a 40% increase in complication rates that needs to be addressed. And quite simply, what I'm going to talk to you today about is work we've been doing with the NHS, started off with NHSE and NHSI, but now pushing towards 25% of trusts to really address this elective backlog. So if you go to the next slide, please. So on the left-hand side, the prioritization system outputs a number of things which support decision-making. That's the risk of mortality and complication for the patient today, the risk of mortality and complication if they're an emergency. So what's the increase that occurs? So you can see from that, you can start to think about the patients who should be prioritized and seen earlier. But we create a matrix score, which also includes the surgeon's priority code rating, the length of time that somebody's been on the waiting list for, to create a score between 0 and 100. And I'll come to why that's important in a second. But as well as just simply understanding the prioritization of patients who should go first, reducing harm, mortality, and cost, it's about then saying who should go where. So if I have a patient who's perhaps isn't going to deteriorate, so their mortality rate or complication rate isn't going to change, but those are both high, I know I need to send them to a kind of either a center of excellence, or they need to stay in my hospital. But if I can essentially sort on clinical urgency, we can figure out who should go to the independent sector. And of those being sent previously in part of an NHSE, NHSI sponsored trial, up to 60% of patients being sent to the private sector were then sent back to the hospital. And you can imagine that's very upsetting for the patient, but it was simply because they were deemed to be too high risk. Since working with the system, 100% of patients go to the independent sector and are seen by the independent sector. But also you can start to think about settings where you may have no HDU. So you want patients who've particularly got no risk of serious chest infection and some other major complications that, again, we give specific risks on to enable patients to be sent to the right location. It also supports prehabilitation. So in one case, if I'm having a particular operation and my physiology is normal, my risk of death is 1.6%. If I have abnormal sodium, it goes up threefold. If I have abnormal sodium and blood pressure, it goes up tenfold. And my risk of complication goes up 4x as well. In that case, using the system, the clinicians can actually identify those patients who should basically be sent back to their GP to be made well until they're well enough to have their operation, or in longer term parlance, to wait well. And we're working with NHSX on projects essentially identifying who should go back and whose underlying comorbidity should be addressed before they're operated on, but perhaps they're P4 patients. If you just give us a quick click on that slide, should see some numbers appearing. So the top, this is able to save 5 minutes per patient per triage. To be honest, this is a massive underestimate, because that is assuming that one surgeon does the triage. These are NHS quoted figures, by the way. It shouldn't be one surgeon. The Royal College of Surgeons said it should be multiple clinicians. And the thing that's actually being missed here is something I'll come on to, which is that even if you have people perfectly categorized into P2, P3, P4, that can be a 20,000 patient list. We know trusts we're working with who have 72,000 on the list or 80,000 on the list. So at that stage, there's a huge black hole of extra work to do the prioritization. It's exceptionally difficult to get right. It will lead to avoidable harm and mortality. And that time saving is not even estimated. But across the NHS, that's something like 6,000 surgeon years of time that will be lost in doing prioritizations if they don't use our system. We're also reducing down emergency admissions by up to 8%, which has a huge set of savings that go with that to do with ambulance costs, to do with admission costs, etc. And again, NHS quoted 125 bed days saved per 1,000 patients through the reduction in avoidable harm, etc. If you just give another click, please. So what's interesting is that our output is a score between 0 and 100. So if you look at that detailed list of 20,000 patients, you can more accurately position patients than simply P2, P3, P4. But what we did was we looked at those prioritizations that were going on in hospitals, and we could see there was a mismatch between what we suggested and what surgeons who are following the Royal College of Surgeons guidelines suggested. And what we saw was there's a lot of scope creep, there's a lot of concern that other people may be gaming the system, and a lot of variation. When we talked to the surgeons where there was this 15% difference between our P code and their P code, in 94.7% of the cases, they actually agreed with our categorization and they changed to our code. And what was really good was in 5.3% of the cases, they didn't. And that's because they knew the patient was in significant amount of pain, was having issues with medication. So they used the clinical acumen and said, even though, this should be a P3, I'm actually putting this patient as P2. So that was fine, but gives an indication about the level of trust that there is of the system. We're able in the first 6 weeks with one hospital to support a 27% reduction in long waiters, but using the Gregorian calendar to actually prioritize clinical urgency is pretty poor. This is about this detailed clinical urgency. Next slide, please. So on the left-hand side here, if we think about that massive long list of patients, even if the P coding is done correctly, you may still have thousands or possibly tens of thousands of patients who are P2, and across the specialties, you somehow have to come up with the best use of resources. Because we have this priority score, this matrix score between 0 and 100, that means that within a specialty, there may be just a handful, possibly tens of patients with the same score. So you can, with far more granularity, position patients on the list. And because you're also seeing this detail that's not in the P coding to do with the risk of mortality, risk of complications, what dominant complications will be, you can also assess which patient should go to which site. On the right-hand side, just to say that with the system, it's on HSCN, we're ISO 13485 27001, secure upload, secure download. But you can also go online and actually play with the list and say, actually, I'm the head of urology. I want to see my waiting list. And I want to look at people who are waiting more than 26 weeks, who are originally coded as P3 or P4. And it enables you to then download a CSV file. So you can do both the high complexity patients, but also create a super Saturday or a perfect weekend list very quickly, as opposed to some of our clients who said that they were previously just going through piles of letters. Next slide, please. So the middle two blocks essentially show this system uses information that is already available in the hospitals. and systems which have been built around the world's largest data set with 375 million patient records from 46 countries, based on 30 years of research by the developer of the POSSUM preoperative risk assessment system and the advisor on the American system, NESQIP. We've taken these two systems, both in use in the NHS and other countries around the world, including the US, combined them together to say, look, let's identify the comorbidities. We'll look at 2 years of HES data. The system will automatically, into high accuracy, identify comorbidities for patients from that. And we're covering about 92% of patients having comorbidities that we find with that process. And of the 8% that we don't find comorbidities for, their average age is about 30. So typically they're not patients who've been in hospital during that period and they're relatively low risk. We combine this with the OPCS codes and the patient waiting list, essentially grind that together, a huge number of calculations and permutations that are considered within that, to then give these outputs, such as risk of mortality and complication today, the delta on those if the patient waits and comes in as an admission, and also what the dominant complications will be. So you can identify someone's got a high risk of chest infection. You don't want them to go into a surgical hub that doesn't have HDU. Next slide, please. So this is an example of the output that you'd see on screen with the online system. The most important one here is to say on the right-hand side, that's the scoring that you see for each patient. So you can prioritize patients with that score. And this is to do with their risk of deterioration, as it were, what happens if they come in as an emergency operation. Some people certainly won't have that issue. So often we're seeing people prioritizing using that score on the right-hand side to start with, and then looking down more finely at the risk of mortality and complications to say, okay, of these patients I need to see, this patient has a higher risk, we'll keep them here. These patients have lower risk, we'll do a weekend list here. These patients have super low risk, we'll send them to a surgical hub. Next slide, please. So the system's being used, it's trusted in action. The top slide is for a particular period of time in a hospital. And according to our matrix score, which is the higher is the higher risk, the orange blobs there are patients with a matrix score of more than 50. And we typically see them going up to about 91, 92. That's very, very serious risk. Over the 6-month period, you can see that those highest risk patients, based on clinical urgency, which is how this should be done, and in a non-discriminatory way, which is how this should be done, those numbers have reduced. But also those lowest risk patients who are in that less than 10 priority score category have also gone down. So this isn't just about let's do the highest risk. This is about also informing those super Saturdays, those perfect weekends. In the second example, the impact B, we can see that 6 weeks into using the system, the highest priority scores are closest to the left-hand side axis. And you can see that the original in dark blue is higher than the 6 week later period, which is teal, other than from the 80 to 90, where a few of those patients just crept in. Essentially, every score above 30 had gone down. What that tells you is that the surgeons trusted the output of the system, felt that it was right, and have been therefore using this as a guide to their decision making on who gets seen, where, and when. Next slide, please. So an important piece, a lot of information on here. Essentially, social determinants of health determine your health. You should not be artificially bumped up on the waiting list because of your length of time living in a postcode area. We see that patients who have poorer social determinants of health have more comorbidities and therefore appear higher up the list. So in simple terms, with those who've got a complication risk above 20%, if there's 100 people from a European affluent area, we will find 155 people from Afro-Caribbean heritage and 183 people who are European but from a deprived area. So this is automatically taking account of social determinants of health, but in a scientific way. Next slide, please. Go to the next slide. Moving very slowly. The most important thing here, it's no point having clever IT systems if clinicians don't want to work with them. We're lucky that we've got hospitals from King Edward VII, London Clinic in the UK, Imperial, Karolinska, etc., all supporting what we do, and surgeons becoming both huge advocates for what we do after a process of initial challenge where they're asking us very hard questions. Because of this, we're working with pretty much every major consultancy, also with one of the two largest EMR systems in the world, and probably the most notable systems integrator in the UK, because they recognise that what we're doing is making a difference. This came from NHS and I. They're very supportive of what we do. Just if you can say next slide, please. So overall, about 6,000 surgeon years of time that can be saved in the NHS, a huge number of lives, about £2.4 billion of surgeon opportunity cost reduction in cost for avoidable harm, etc. Up and running in days, using information that the hospitals already have, very little discomfort to the IT team, and with all the IG automatically put in place. And I think that's my time, so I'll stop there. But thank you very much for your attention.
Thank you, Richard, for such an insightful presentation, and well done. It sounds like you're doing some cracking work there. I noticed Jane on the Q&A panel said that she'd love to get a copy of your presentation, and I'm sure that'll be possible through our platform. So we move on to the final debate of the day. At the forefront of planners and operational leaders' objectives to reduce the NHS backlog is the effective streamlining of hospital processes to address patient flow. Approaches to optimise patient flow and meet demand for care can be achieved by coordinating patients moving through various care pathways to diffuse traffic while still improving of care by ensuring patient treatment is delivered in a timely, efficient and effective manner. Providers strive to successfully match the appropriate number of resources to each of their admissions to optimise patient flow, patient safety and health outcomes. We'll also hear from our experts, new programmes and initiatives, as well as the potential barriers experienced. And we'll see the discussion, I'm sure, overlap between the panels that we've already done today, as other concerns, including funding, downtime and training issues, will be touched upon, as we can't look at things obviously like infrastructure separately to recruitment and patient flow. So to help us navigate patient flows, our last group of panellists are Alex Afifi, Senior Project Manager, Northern Lincolnshire and Goole NHS Trust, Stephen Rocks, Economist for the Health Foundation, and Seamus McGeer, Director of Nursing and Urgent Care at NHS Midlands and Lancashire Commissioning Support Unit. And actually, Seamus, I just wondered what you thought to Richard's presentation, presuming that you were able to hear it.
Richard and I have met before, and I thought it was a great presentation of this approach in terms of risk stratified, which is another word for triage, if you like, is ideal. It's key that we get the right patients to the front of the queue, that we reduce the harm, that we maximise the capacity in our NHS systems, which are at an all-time low at the minute for stuff we'll discuss in a minute or two, without doubt. So anything we can do to get the right patients to the surgeons and interventionists as early as possible is absolutely key, whilst we're in this tough stage we're going to be in for, I think, a few years.
Absolutely. Stephen, what's the overall size of the NHS elective care backlog? And can you explain its impact on patient flow?
Yeah, of course, Helen. So the current elective waiting list stands at just over 6 million people, and that's already a record high, and we've hit several records since the pandemic began. I think the concern regards that waiting list is that it might only be the tip of the iceberg. So during the pandemic, a lot of people, and we'd estimate maybe 8 million, it could be as high as 10 million, that we would expect to have had a referral during this period didn't come forward. So these are so-called missing patients, or maybe it's better to say missing referrals, because obviously the same patient could have several referrals. So if you take that into account, it's projected that the waiting list could grow to over 10 million, for instance, quite feasibly. So that gives you a sense of the overall scale of the backlog. And that's obviously putting pressure, or would put pressure, on all parts of the system, from patient referrals by GPs through to diagnostics, which we can see already record waiting lists for diagnostics as well, through to treatment, and also discharge of patients too.
Alex, you're in my neck of the woods. I mean, these in Lincolnshire, I'm from Lincolnshire originally, these aren't records that we want, are they? These record highs that we're seeing. And I'm just wondering how you're getting on in North Lincolnshire and Goole.
So we're currently piloting a very transformative method of managing our outpatient backlog. And what we're doing is completely transforming the traditional outpatient model, which typically sees primary care and secondary care operating in entirely different spheres. And as we all know, patients get referred in from primary care by a GP into secondary care, and they instantly go onto a waiting list for a new appointment, and they will then go on to have further diagnostic waits and further follow-up waits. And there are lots of inherent handoffs within that system until eventually the patient comes out of the other end of the secondary care machine and gets discharged back to the GP. And then the GP re-refers again if they need further assistance. So it's not really a model which is built around the patient in the first instance, it's built around the system. So when COVID happened, the senior clinical leads across Northern Lincolnshire all came together, and they wanted to try a very different approach to patient care, which was a model based around the patient. And in this model, we specialist from secondary care into the primary care system with the aim of managing patients within primary care without pulling the patients through into the secondary care system. So it's much more of a partnership way of working between the specialist and primary care.
Oh, fantastic. We'll hear more about that in a minute. I just want to bring Seamus into our discussion. I mean, Seamus, why is the NHS experiencing the current planned care backlogs? And that's an obvious question, and I don't think it's necessarily a really obvious answer, is it?
No, it's not an obvious answer at all. There is an assumption that footfall, that's people over the threshold of hospitals and health systems, has increased, and that's not true. The reality is the numbers that we're seeing coming to hospitals at the moment are actually lower than they were pre-COVID. And that does two things. It adjusts the case mix because the sickest patients can't not come. The wellest patients, however, or the middle sick patients, as we describe in Irish, they're and the wellest patients are coming less and less to hospitals. So we've skewed the case mix. That means that the pressure on clinicians is much more intense than it was before. I estimated yesterday for a trust on one of my patches that, in fact, compared to January 2019, comparing January 2021, they had 93 more people over 65 in bed than they had the 2 years before. That compares to 9 adults under 65 more. So we've seen this massive growth, particularly in the inner city hospitals and in the specialist hospitals, where the case mix has both changed in terms of age and in terms of complexity. I don't really like the acuity word. So what we've seen is populations that were young get very old really quickly in hospital. What we've seen is the case mix in our A&E departments change. And what we've seen is a virtual collapse of our direct admission rates. So prior to COVID, we saw direct admission rates of 40-50% in some really well switched on systems. And those well switched on systems have reverted fastest because of infection prevention and control rules. So we have interpreted the national rules a wee bit too robustly, and we're not sending patients with any respiratory challenge at all to some of our medical assessment units or SDEC units, and hence they're going to emergency departments. By going to an emergency department instead of going directly to the definitive decision maker, you add at least a day to the length of stay. So our hospital occupancy has risen even faster than our old people's admission rate has gone up. And people don't calculate that out. So when I did this for an ICS a few weeks back, what we discovered that actually, in reality, based on their activity, they should have 84 more beds compared to a pre-COVID time. But the reality is, when sickness rates went up among nursing staff and medical staff, physios, pharmacists, and porters, all who that's a reduction in real capacity. When we looked at the shift in length of stay, we lost a quarter of our non-elective capacity. So those same number of patients come in, then occupy a significantly greater footprint of the hospital, and they squeeze out the elective patients. In 2 ICSs that I spoke to yesterday and last week, they have up to 75% of their surgical capacity occupied by medical patients. And the primary driver for that is that whilst the population in hospital got older, and there were more old people in hospital relative to younger people. But we had the same conversion to support, needing support to step down. And we just don't have that level of support because we built our systems for a better time than we've got now. So our social care colleagues can't get patients out of hospital because they don't have those facilities. Let me use an example. In Lancashire, there are only 0.6% of the female population between 18 and 65 out of work. So their care homes cannot recruit. And we need 25% more care in the community than we had pre-COVID. So taking this blind view that activity has gone up and that's the driver is actually leading us down the garden path, because if we get the wrong diagnosis, we get the wrong treatment. So it's a bit NHS is you'll have heard the term complex adaptive. We're not complex adaptive, we're complex unadaptive. And hence we're not able to keep pace with the changes that of the inpatient population as quickly as we would like.
That was very well explained. Stephen, I noticed you were nodding away there. You look like you agree with a lot of what Seamus was saying.
Yeah, absolutely. That really chimes with a lot we've heard. I mean, certainly if you look at social care, especially domiciliary staff, the number of staff has fallen this year. Care homes that haven't been able to take in patients during the pandemic because they've had to close and so on. I think that's putting a lot of pressure throughout the system. Community care, which hasn't really kept pace at all in the last decade, at least, in terms of the demand. All those things, would resonate with what we've seen.
And other risks, Seamus, to sort of restarting planned activity at pre-COVID rates that may not be, that you kind of touched on in that answer?
Yeah, I don't think it would, but it might be pushing it a little bit to say we've got an existential threat to some of our specialty services, but that's my personal belief. So this time a year ago, our critical care units were on their knees. We have critical care staff working 100-hour weeks. And really, I need those people to have the sufficient rest for when I'm ill enough to need critical care. This year, that's reverted to a different pattern. So we've got normal seasonal February illness. We've got still about, on the patches that I cover, about 14% of our beds occupied by COVID. And the general public is of the view that COVID is over, and it's far from it. Mm-hmm. We've got some sick patients who have sat on waiting lists for an awful long time who are now accessing the care that they were on the waiting list through the emergency department. And what we've got is a huge pressure on the staff in A&E departments. Now, I won't tell you the trust that I discussed this with, but it's a long way away from where I'm sitting at the moment, where the chief exec told me that she fears that she will lose 40% of her emergency care staff this year. Now, that's a threat to the way that we do business. So we have to unlock the non-elective pathways again in order to unlock the A&E departments. Busy A&E departments admit more patients as a proportion, not just as a number, because you don't have time to think. This was my proper job way back in the day. And you need space to make good decisions about patients. So the risk is that we lose our A&E departments as we understand them. A critical care nurse, an A&E nurse, and a coronary care nurse, a specialist nurse of any kind takes about 8 years from scratch to build. So we would suffer this impact for 8 to 10 years if we don't unpick the real reasons why our trusts are under pressure. It's worth though pointing out, I don't see anybody who's shirking their responsibilities, but to use the line of a colleague, a guy called Jimmy Stewart, we damage more patients by poor process than poor medicine. And similarly, we advantage most patients by good process as well as good medicine. So we have to go back and look not only at the quality of our clinicians, but the processes we're asking them to endure.
Some very wise words there. Alex, just going back to, the new things that you're trying out. By the way, is it the Connected Health Network you're referring to when you talk about
Yes, it is.
It is. I thought it was. And just how's it going? You kind of set the stall out nicely for us. How are you finding it's helping?
Well, it's helping significantly because I suppose a lot of schemes which are aimed at reducing the backlog of outpatients tend to focus on when the problem's already in the hospital. But this is much more preventative, I suppose, because by working in partnership in primary care with GPs and all the other GP clinicians that work within the primary care. We are actually, in our cardiology pilots, we're managing over 75% of patients in primary care. So less than 25% of patients are having to come into the hospital system. Now, from an NHS England perspective, their ears tend to perk up when you say you're managing more than 30% of patients, avoiding those patients going to the hospital. So we're achieving 75% of new referrals, managing 75% in primary care. So it's really going incredibly well, having that partnership working between the specialist and the GP.
That sounds fantastic stuff. We're just smiling, Seamus, because somebody's mentioned on our live Q&A there's a bit of cake eating going on in the background. I think they're a bit jealous, actually. Don't say anything, because she's absolutely fine. She's looking very busy in the background. Stephen, when we consider improving patient flow, do we need to consider different areas and different specialties separately, or do they need to be looked at as a whole?
That's an easy, yeah. There's certainly a yes there, isn't there? That's a, and in particular, I think if we look at if I think first about what the current waiting list looks like, there are big differences pre-pandemic as well. So there's an increase in the proportion of people on the waiting list that are in London, the Northeast, the Southeast. I think there's proportionally fewer from the East of England and the Midlands. But then again, if we think about possibly some of those missing referrals and some of the demand that we'd expect to come forward, that's disproportionately in London, the Midlands, and the Southeast. Which I think account for about 50%, I mean, depending on the method and so on, that would account for about 50% of some of the referrals you'd expect to see coming forward. So it's not going to be evenly spaced out over the country. So that has obviously challenges about how you build the supply for meeting that. Obviously, there's the intention in the elective recovery plan to look at things like surgical hubs and to increase, patient choice and so on, so that patients can go to a hospital other than the one that they might first have chosen. I think historically, and I'd be interested in getting the panel's views on this, patients don't always want to travel or may not be able to travel further afield and take time off. So I think there are going to be challenges there. Yeah.
Do you find that, Seamus?
In particular, our oldest populations have the most difficult traveling. We have to take account of that. The general public is not as informed as we collectively are in this conversation, and we need to meet people's reasonable expectations as well as their needs. Some of our deprived populations similarly are not able to travel long distances, and what we're starting to understand now is that COVID has actually extended our inequalities rather than reduced them. So it's harder and harder for some people in deprived areas, multi-occupancy housing, low-income areas, to travel to the big sites. We have to take our equality duty really, really seriously, and make sure that those populations that were hardest hit by COVID, they're hardest hit by the economic factors that we have going on, and we can have them hardest hit by the health choices that we as health leaders put in place for them as well. We have to actively discriminate for them, and the system is currently discriminating against them.
That's exactly what we were talking about in one of the panels this morning, actually. I just noticed, Alex, Jyoti's got a question for you. Would the patient still need to come in hospital for diagnostics?
So we aim to carry out as many diagnostics as possible in primary care. However, there are certain specialist invasive diagnostics which do need to come into the hospital. So where those invasive diagnostics are required in a hospital, our shared admin team, which is a combination of admin from secondary care and primary care, we will arrange those diagnostics in secondary care for the patient. So we make that whole journey a lot smoother. And then as soon as we get those results, we will then follow them up in the connected health network clinics, which are primary care based.
What would you say, just while we're with you, Alex, what would you say are the key enablers, and also what are the main challenges that you've been dealing with?
So there are a number of enablers. The most important one, I have to say, is using the GP's primary care clinical system, because they really do have a wealth of information on the patient, which by giving our consultants access to that information, it's very informative. And we obviously have to train our admin staff and our consultants on how to use that system, which is new, but they've taken to it quite well. And they will update the primary care information system to ensure that the information is up to date on that patient. So that is a key enabler. Obviously, what we had to do was create some bespoke templates within those systems, either System 1 or EMIS is what we use locally. But we made those very straightforward and basic as possible for the consultants to complete. And we enable them so that either a consultant, the specialist, the GP or admin can input into those templates. So we've made them as flexible as possible. One of the challenges for us at the moment is, I suppose, from an accounting and coding perspective, because what we do in primary care isn't counted at a local or national level. So we're having to duplicate that information input into our own hospital systems. However, we do have plans for that in the future over the next coming months about how we can get away from that duplication. But it really is a critical factor for the Connected Health Network to use those primary care information systems. And I think if we didn't use those systems, then it goes against the whole ethos of keeping the management of patients in primary care. And I think as soon as you send a patient into the secondary care system, you sort of lose that sense of ownership at a primary care level. So it's very different to the traditional outreach clinics where you just basically send a consultant out to carry out what in effect is a hospital clinic. It's not like that at all. It really is working in partnership, and actions that can be carried out at a primary care level are carried out by the GP practice. And we really only do have the patient going into hospital where absolutely necessary.
Oh, it sounds.
Helen.
Go on, carry on.
Well, could I just ask Alex? I mean, I don't know how much pressure is this putting on primary care? Because I'd also understand primary care, that the workforce to be very stretched. Is this creating additional work for primary care, would you say?
I would say overall, it actually leads to probably a reduction for primary care. So from a primary care perspective, what they want is, I suppose, a little and often approach. So rather than coming to us when the problem has just got significantly worse, quite often they just need a management plan to be able to continue to manage that patient in primary care. And also they know that they have the backup of the specialist. So it's very different to when you refer a patient into a system and then you don't hear back for a long time, and you feel very disjointed from that process. In the Connected Health Network, they feel very connected with the specialist. And so they feel much more confident managing the patient in primary care with an agreed plan, because if there's any deviation from that, they know that they've got the backup and instant access to the specialist for advice.
Do you have any questions, Seamus, about what Alex is talking about?
We're toggling the mute button between us. We've been looking into this quite a bit, and what we've been seeing is that if we're going to get through this tough period ahead in the NHS, we have to treat the straw that's breaking the camel's back, because the camel's too big to treat, if you like. The straw that's breaking the camel's back at the moment, which happens every winter, but's happened this winter more so than any other time, is respiratory disease in mildly frail patients. I'm wondering what primary care can help us to do. So when I look across the populations that I'm responsible for, only about 8.4% of the patients over 65 have got a frailty score, and therefore the remainder can't have a care plan. In order to keep patients at home, I'm wondering how we get that number up so that our GPs can have a care plan that's agreed with the patient should they get into extremis, which doesn't require them to lift the phone and phone 999.
Alex, do you have a response there?
I mean, we haven't piloted respiratory yet, but it is on our list of specialties to pilot in the future. So we are very interested in how we can carry out a pilot in respiratory. I think the key for us would probably be to look at doing that in the summer months, when we're not in the peak crisis period in the winter months, because the respiratory consultants are absolutely snowed under, as everyone knows. But it is on our list of specialties to pilot.
Stephen, let's just talk about funding a little bit, if we can. How much funding is needed to meet the elective care backlog?
I mean, I think it depends over what time span and what's really meant by meeting the backlog as well. So we did some funding estimates prior to the spending review, and we actually thought it might require up to about £17.5 billion to clear the backlog by the end of this Parliament. Now, the government's put forward 10 billion for the elective care recovery, but that's a different set of targets as well. So they're thinking mostly then about prioritising long waits, which might seem sensible because whilst we had a higher estimate, it may not have been feasible because, to be honest, at the end of the day, the money is not going to be able to do anything without bringing forward the capacity. I think Seamus raised a really good point earlier about how long it takes to train a skilled nurse, for instance. So there's likely a time span there. But yeah, I would just mention there's an awful lot of uncertainty, of course, over, again, this idea of missing patients, missing referrals, and how many of them will come back, when that will happen, and again, what the severity of patients might be. So how many are going to need admitted patient care versus non-admitted, for instance. So there's a lot of uncertainty.
There absolutely is. And Seamus, why can't... Oh, go on, you carry on.
Yeah, I just wanted to ask Stephen, does he think that analysis, that cost analysis is based just on the cost of the elective activity, or does it allow an amount for fixing non-elective activity so that the bubble on the balloon doesn't pressurize the elective activity out as well?
Yeah, so that was additional and over above our sort of underlying pressures, as it were. Because, of course, all this time, if we're speaking about the elective backlog and that recovery, we have growing demand across the health and social care system, and that includes in particular emergency demand, which in our projections was actually the area that we saw growing most over the next decade, because of that rising ageing population with greater morbidity and greater complexity as well. So that, yeah, the 17 billion was over and above that, yeah.
Another question, Alex, for you from the floor. It always does this. It disappears when I'm just about to ask it. Hold on a second. Most cancer diagnoses need imaging for diagnosing. So that's kind of like a statement, but I suppose you were trying to avoid bringing people into hospitals where possible. How does it work? I suppose you do have to when you need imaging, do you, or not? Or can you do that remotely?
Well, so for the cardiology pilot, as I say, the invasive diagnostics do need to be carried out in secondary care. But the majority of diagnostics in cardiology are actually carried out in primary care. And you can manage the vast majority of patients in primary care. Taking a more challenging example, we are currently setting up a pilot in gynecology. And we're looking at a postmenopausal bleed service, and we're looking at setting up a one-stop service in the community, running them through the CHN clinics as a one-stop service. And what we would do as part of that service is that we will actually have the transvaginal scan carried out at the GP practice where we're going to carry out the clinic, and they actually have a local. They have a minor procedures facility in their GP practice, which we would actually be able to use to complete the entire patient journey in that one day for those patients that needed a cystoscopy procedure.
That's incredible. A question from Richard, perhaps for you, Stephen. Do you think that paying hospitals on block contracts instead of by activity could be the right direction of travel?
Well, that's certainly part of maybe the envisioned direction of travel because of the shift to ICSs and population healthcare and so on. I would say there is some evidence that payment by results has led, for example, incentivized hospitals to reduce length of stay for given procedures where that's feasible and so on. I'd say there's possible that a blended approach might be the best, or might be what's most likely going forward.
Seamus, what do you think we've learned during COVID, during the pandemic, about planned care that we should really retain in case, God forbid, we face another pandemic like this?
Well, what we've learned is that leaving people on waiting lists for a long time is a really bad idea. It generates non-elective presentations of people who are significantly further down the disease route. They're further compromised. What we've learned as well, though, Helen, and hats off to colleagues that are at the front line, is that the NHS can do wonderful things even in the middle of the biggest disaster we've ever seen in the lifetime of the NHS. And what we've also found is that we put some people on lists who didn't really want to be on them. So we need to go back and look again and ask with the patient, you know, do you really want this operation? Because we've offered lots and lots of patients operations who are nice and they're sitting on lists and they don't want to come to hospital. What I think we've applied our collective technical and clinical and managerial knowledge without fully understanding the patient's perspective and everything, because, you know, do we really tell patients that you can have your hip revised twice but not 3 times? Do we really tell people the reality of what we're going to put them through in order to make their life 5% better? But what we have learned, Helen, in a way that's abundantly clear, is we can work together when this, you know, when we have a common goal, we can work together far, far better. I publish data every day to all the directors of adult social care, all the directors of public health, all of the chief executives on my patch, and all of the directors of ops. And they're very happy to not be in competition with one another. So I would learn the lesson that we're all here in this together and never go back to active competition.
I think, Seamus, you've ended not only today's panel, but you've ended our conference on some very wise and thoughtful words there. And I think what we've also learned, and it's something that we discussed right at the beginning of today, is that we have some wonderful people working in the NHS who have done a cracking job and who are exhausted after 2 years of, you know, unprecedented times. So we have to take care of them, retain them, and look after their well-being as well in all of this, I think. And just a lovely comment, Jane Smith from the audience says, many thanks for an excellent discussion and day. Stay safe and smiling. So we'll also end on Jane's words there. But thank you so much. It was lovely to meet all of you. I hope we'll see you again. And I hope that's your tea that's been getting done in the background, Seamus. You've had whatever's going on in your kitchen looks delicious, just saying. So you can go and investigate now.
It's gluten-free cake baked by a GP.
Wow, gluten-free cake baked by a GP. Fantastic. I look forward to a slice of that in the post. Brilliant. Lovely to meet you all. And thank you to everybody who's taken time out to join us today. Gosh, haven't we covered a breadth of challenges and solutions as we've engaged with the topic of learning and development in the NHS. I mean, whether you're one of our excellent panelists or part of our audience who's been sending in questions, taking the time to listen, or sparking conversations with other delegates, a very big thank you from the team here at NHE365. And thanks to our fantastic event partners who, without them, events like this simply wouldn't be able to take place. I do look forward to seeing many of you for our event on decarbonisation on the 17th of March. Get that in your diary and please share the word with your colleagues and bring them along. If you're a winner in our gamification challenge, then the NHE team will be in touch to discuss your prize options. Separate to gamification, today's event, as you know, was CPD certified with 1 CPD point earned for every hour of live content watched. So if you'd like your CPD certificate, then please email marketing@cognitivepublishing.com and they'll sort it out. From me and from everyone at NHE365, thank you for attending today and giving us your time and attention. Have a great rest of your day. Bye for now.